Good evening, everyone. Thanks for joining us. My name is Megan Woods, and I work with the Epilepsy Association of Western Central PA. I'm the Community Education Coordinator out of the Pittsburgh office. And tonight we'd like to thank and welcome Dr. Joanna Fong-Isariyawongse for taking the time to join us for this evening's webinar series. Dr. Joanna Fong-Isariyawongse is a neurologist specializing in epilepsy and sleep medicine at UPMC. She has extensive expertise in managing epilepsy, critical care EEG, and sleep disorders such as sleep apnea and insomnia. A passionate advocate for sleep health and public policy, she has been actively involved in legislative efforts to delay school start times for adolescent health and testified before the Pennsylvania Senate Education Committee on this issue. Dr. Fong-Isariyawongse serves on multiple national committees, including the advocacy committees of the American Academy of Sleep Medicine and the American College of Sports Medicine, as well as the Health Policy Subcommittee of the American Academy of Neurology. Recognized for her exceptional patient care, she has received UPMC's Excellence in Patient Experience Award and has been named a Pittsburgh Magazine Best Doctor annually since 2019. We appreciate you all joining us tonight. If you do have questions throughout the presentation, we ask that you put them in the chat and we will answer them all at the end. And thanks again for joining us, Dr. Fong, and take it away.
Okay, hi everyone. I'm gonna go ahead and share my slide here. Just a couple more clicks. Okay, you guys can see the screen okay?
Yep.
Perfect. I'm going to minimize this screen so I can see. Okay, perfect. So today we're going to talk about sleep and how it interact and affect epilepsy and how epilepsy affects sleep. It's a bidirectional relationship, and I think it's important to really spotlight the importance of adequate sleep and good quality of sleep. So I'm a neurologist by training, but my expertise is really in sleep medicine and epilepsy. But the role that I'm most passionate about is really to be an educator and advocate for sleep health, especially for adolescent sleep health. So I do all kinds of education and training for the general public, and that's include, obviously the healthcare professionals and neurological patients and families, but also the public transportation sector, both aviation and ground. Very important because they're shift workers. The first responders, same reason, they're shift workers, very challenging schedule, but also underserved communities, children and adolescents. I do a lot of legislative advocacy, mostly in later school start time for secondary school students, but also to advocate for year-round standard time. As well as better healthcare access and medicine accessibility for patients. So we're going to talk about sleep, why sleep is so important. I think the first thing we need to really understand is how many hours we need to sleep. So this is a recommendation from the National Sleep Foundation, and that's the same for CDC and other major health organizations. For adults, we need at least 7 hours. The range is 7 to 9. I would say probably 8 and 9 is healthier if you can get those hours. But if you have kids at home, teenagers, they do need 8 to 10 hours. So make sure your teenager at home get their at least 8 hours. And if you have school age children, 6 to 13 years of age, at least 9. Oh, and I want to point out, this is this kind of sad reality. Actually, 35% of adults not sleeping at the recommended sleep duration. So meaning they're not getting that 7 hours that they need. And for teens, 3 out of 4 teens are not getting their 8 hours of sleep. So that's really actually leading to some devastating consequences, including safety issue, drowsy driving, school academic performance issue, graduation, SAT, GPA scores, and also mental health. And then for children, and that's about a quarter to half not getting enough sleep. And when we do fall asleep, it's not an on-off event. Actually, it's nicely structured. We go through different sleep stages. First, we go through the light sleep, stage 1 or M1, stage 2, N2, and deep sleep. That's your slow wave sleep, or maybe you heard of the term delta sleep. And then we have our REM sleep or dream. And that kind of cycle through 4 to 6 times a night. As you can see here, the second half of the night, you do have a little bit more dream state. So each states function differently. When we do dream, it is really the time critical for memory consolidation. What we learn during the day, that's going to turn into long-term memory, important for performance, important for not just students, for all of us. When we dream, we also process our emotion. It's really the time for us to really process what happened the day before, process those emotions, whether it's good or bad. And when we wake up, we feel kind of reset. And that's the reason why sleep insufficiency or just not enough sleep closely linked to mental health issues. So if you're sleep deprived, you're more likely to have depression and anxiety. Deep sleep, the stage 3 or slow wave sleep or delta sleep, is really the time for us to kind of restore our body, kind of recalibrate our brain, so to speak. It's the time for important hormones to be released, one of which is human growth hormone. Really important for not only athletes, but for a growing child. And also deep sleep or slow wave sleep is the time when our immune system really kick in to survey the body for infection. So there's also a tight correlation between sleep deprivation or sleep insufficiency and more illnesses. And then there's a process called lymphatic system. It's basically kind of like lymphatic system. You heard of lymph nodes in the body. It's almost like a lymph node process in the brain is really for it to filter out waste product in the brain and all these neurotoxic proteins that have been implicated in neurodegenerative conditions like dementia, Parkinson, things like that. And that, I always tell my students, like lymphatic system is like having a dishwasher in our brain. It's really important to get that deep sleep because you're cleansing your brain. So I want to next talk about the link between sleep and epilepsy. Well, when we think about epilepsy, there are a couple of things that we should be considering. So the first thing is interictal epileptiform discharges. You may have heard of that term. Sometimes you may have heard the term sharp waves, spikes, polyspikes. Those are abnormal activity in the brain in patients with epilepsy. It's not causing seizure symptoms, but is an abnormality from the brain, is a surge or brain activity. It's almost like a characteristic of someone with epilepsy. And when you think about when you see these epileptiform discharges or seizure, actually there is a circadian pattern to it. What I mean by circadian pattern, well, these discharges and seizure tends to happen more during non-REM sleep, so the light sleep and the deep sleep. REM sleep or your dreams is actually kind of protective, in a way. When you look at the EEG, you don't typically see seizures, you don't really see discharges during REM sleep. Not none, but a lot less. So in a way, your dream state is protective. And what happened when we sleep deprived ourselves? Some of you or your family member, when if they had EEG in the past, they may have it done in under the condition of sleep deprivation. Is sometimes what we do when we kind of try to get a diagnostic testing with EEG. The reason is sleep deprivation actually irritate the brain and bring out these epileptiform discharges. So in a way, make the test more sensitive, especially if you're looking at diagnosing someone with, epilepsy. So sleep deprivation really can exacerbate seizures and in terms of frequency and also the severity. Um, also, as you know, sleep deprivation is a known trigger for seizures in many patients with epilepsy. If you have a breakthrough seizure or a family member with breakthrough seizure, your doctors may ask, did he sleep deprived himself or herself the night before? You know, so that's why sleep deprivation is you do want to avoid. So, I mentioned EEG before. EEG is a testing where technician put electrode on the scalp. Is in a way for us to measure brain activity, kind of in a non-invasive way. And I don't know if you guys have seen EEG, but this is an example of EEG. It's only like 12, 13 seconds here. I circle the epileptiform discharge. In this case, is a sharp wave. And EEG tell us where the sharp wave is. So in this case, is left temporal region on the left side of the brain, kind of near the ear area. And this is someone with generalized epilepsy. So the example before is someone with focal epilepsy. An old term for that is partial epilepsy. We don't use that term anymore. And this is an example of someone with generalized epilepsy. And if you want to be really specific, this is absence epilepsy. As you can see here, the epileptiform discharges, the spike and wave is all over. So that's why it's generalized. So, what is that link that I've been trying to tell you? Well, I want to show you. So these are the discharges. And what you can see here, right after the discharge, you see that person, e.g., kind of more awake, so something in a sleep term that we use is arousal from sleep. So it really illustrates the point that epileptiform discharges can disrupt sleep, so make your sleep, poor quality. Sleep disorder like sleep apnea can also provoke epileptiform discharges. So it's bidirectional. So the underlying area is when that person had an apneic event, so it's a pause of breathing, and then you can see that discharge came out right after the apnea. So if you do have sleep apnea, I would highly encourage you to get that treatment. If you use the machine, use it every night, because this is why it's so important. I'm a sleep and epilepsy specialist. I always ask my epilepsy patients about their sleep. Do you snore? Do you sleep enough? And this is the reason why. Now, some of you may know someone with VNS, or yourself have a VNS, a vagus nerve stimulation. Is a neuromodulation surgical procedure, is a device like a pacemaker that a surgeon implant to stimulate the vagus nerve on the left side of the neck. And in a way, well, in an indirect way to kind of we're hoping to reduce seizure tendency. But VNS has been shown to worsen pre-existing sleep apnea. In fact, just 2 weeks ago, I read a sleep study, someone with VNS, and with each period of stimulation. VNS work by having a stimulation period and an off stimulation period. So during the on phase, the person had lots and lots of sleep apnea event. So here is just to show you the VNS artifact is when the VNS is turned on. It's about 30 seconds. During the time, there's a kind of obstruction in the airflow, suggesting obstructive sleep apnea. So we're going to talk about sleep disorders. I think that's a good segue to sleep disorders discussion. So obstructive sleep apnea is pretty common. It affects about a quarter of adult men. For female, it's a little tricky. Before menopause, it's less than men, so less than 25%. After menopause, it really climb up to exactly the same as men. So if you started noticing some sleep apnea symptoms after menopause, think about sleep apnea. So what are these symptoms? We know if someone has sleep apnea, most likely that person snore, and they may have symptoms of waking up choking or gasping for air. They feel like elephant on their chest. The bed partner may say, "Oh, you stop breathing in your sleep. I have to wake you up," because it's actually quite scary when someone stops breathing. They, because of the disrupted sleep from the apnea, they oftentimes complain of being sleepy during the day. They wake up feeling not refreshed. Sleep apnea links to a lot of systemic kind of health conditions. It increases your risk for heart attack, stroke, diabetes, all kinds of metabolic disorder, even depression and overall mortality. So how do we diagnose someone with sleep apnea? Well, we actually do need some kind of sleep test, kind of like EEG, but for sleep apnea, we need a sleep test. So traditionally, we have the in-lab sleep study. So you go to a sleep lab. They put some electrode on the head, something on the nose, belts on the across the chest and abdomen, some EKG, pulse ox for oxygen, some EMG electrode in your legs to monitor leg kicking movement. So that's kind of like the traditional polysomnogram or sleep study in the lab. For the past, I think, decades, a little bit more than a decade now, we have home sleep tests. Home sleep test is best used if someone has, I would say, like a high probability of sleep apnea. So they snore, they have witness apneas, they are sleepy during the day. Your classic sleep apnea patient, home sleep test is sufficient. If someone like pretty thin, not the classic sleep apnea patient, they don't complain of snoring, but you want to understand why the person is sleepy. I would say don't do home sleep tests. Do the in-lab sleep study because it's a better test. It's more sensitive because you get a lot more measurements. If you do have sleep apnea, you do need to get treatment, and the first line treatment is CPAP. CPAP stands for continuous positive airway pressure. It is a machine that actually brings normal air in the room, pressurize it, and open up your airway. You have to wear a mask. That's where the pressurized air kind of flow into your airway to open up that obstruction. It's a very simple concept. It's very effective, and that's why it's the first line treatment. I would say more than half of my patients use it once they love it because it really helped to get rid of all the sleep apnea. They sleep through the night. The oxygenation is good because whenever they stop breathing, oxygen drop, and that's why it's such a health risk for the heart, the brain. But yeah, I would say maybe 30, 40% of the time patient they struggle a little bit in the beginning. And most of the time is related to the mask. The mask has to fit on the face because it's a pressurized system. If it's not fitting the face, the pressurized air is gonna like leak out. So I always advise my patient, if the first mask does not work, don't give up. There are literally more than 100 different masks out there, different size, different way to strap it on the face, different kind of tubings. So just troubleshoot with the medical equipment company. So that's kind of like the last 30-40%. And then maybe 5-10% of the time patients really try and they just can't use it for whatever reason. Then you look for alternative treatment options. So if you have mild sleep apnea, mandibular advancement device is basically a customized mouthpiece made by sleep dentists. So they're they have special training. Not all dentists make these type of device. And the idea of these things is really to push your lower jaw forward. You see this gauge here.
Dr. Fong, you muted yourself.
Huh. And
Not sure how
what
that
was
happened. You're good now.
You're
okay?
good now.
And you heard what I said just like 10 seconds ago. Do I have to repeat the mandibular advancement device? We're good? Okay,
Yeah, we're good.
Okay, I didn't know when I accidentally mute myself. So, okay, good. So yeah, the idea is to kind of advance the lower jaw out, and by doing so, it create a little bit more space in the back of the throat to open up the airway a little bit. But as you can see, there's only so much you can advance the lower jaw. We're limited by our jaw. There's actual joint here that we can't just protrude as long as far as we want. So there's only like just about less than 1 centimeter that we can do. I would say most of the time people can only do like about 0.5 centimeter or so. So it's reserved for mild sleep apnea. Let's see here. Now I can't advance. Okay, here we go. So you may have seen on the TV commercials about a new technology called Inspire. So it's like a pacemaker device. Is a very tiny thin thing that a ENT surgeon implant. It has a stimulation electrode that stimulate the hypoglossal nerve. That's the nerve that control the tongue. So in a way is to prevent, it's more complex than that, but it's in a way to prevent the tongue from falling backwards to obstruct the airway. It's quite effective. It's a same day procedure. You don't have to stay in a hospital for long. And usually insurance don't pay for it unless you really try and failed CPAP. And also you do need to be at least have moderate degree of sleep apnea. So mild, you don't qualify for that. Okay, the next sleep disorder is insomnia. It's very common, I would say, about 10% of the general population. But when you look at patients with epilepsy, it depends on the studies that you look at. It really ranges pretty widely. About 30% up to 75% of patients with epilepsy have some kind of insomnia. When we talk about insomnia, we think about problem falling asleep, but insomnia can be problems staying asleep as well. So, I would say for epilepsy patients, you kind of want to look at your medication, not just seizure medication, some common medication that, can make it harder for you to fall asleep. But when you look at seizure medication, the ones that really can cause insomnia come frequently is lamotrigine or lamictal. So I always advise patient, especially if they have insomnia, the evening dose of lamictal should not be right before bedtime. And then, think about other seizure medication you're on or other medication you're on. If they're sedating, you can strategically use it at bedtime to help with sleep. So, you can kind of look at things both ways. A lot of the seizure medication can be sedating. This is not meant for you to read through, but just to show you there are a lot of medication, seizure medication out there. They most of the time can cause sedation. Insomnia, I would say, in general, is a behavioral problem. I would say at least 80% of the time is a behavioral problem, behavioral issue leading to insomnia, whereas the last 20% may be medication induced or something that truly kind of organic, causing the insomnia. Because it is a behavioral issue, you do want to treat it by changing the behavior. So when we think about insomnia, it's really a cycle of negatives. The negative emotion associated with the insomnia, the negative behavior associated with insomnia, and the negative thoughts. So how do we break that cycle? Well, it's really through three things: education, behavioral change, and cognitive change. So that's why cognitive behavioral therapy for insomnia, or CBTI, is so effective. Study has shown that CBTI works great for insomnia. When you look at CBTI and sleeping pills, CBTI is probably more effective. And if you just combine both, sometimes you see even better effectiveness. And the idea of the CBTI is really to restructure that thoughts process and also the feelings associated with the insomnia and the behaviors. Again, just to break that vicious cycle of negative, thoughts and behavior. Okay, so we're on track. So I want to end with some really practical sleep tips. Some of them are mundane, but very important. They are really the golden rules. So I do want to go through them. And that should leave us enough time for questions at the end. So the first thing first is really be mindful of how many hours you get every night. If you think about how many hours you slept last night, you really do have to think about that. So I think by keeping track, it can be as simple as just writing down your bedtime, your wake time. Or if you're fancy, if you have a kind of sleep tracker or a smart watch that tracks sleep, you really can have a kind of a better look at your sleep duration trend. I think sleep wearables, these sleep trackers, they're great. I think overall they do increase your awareness of your sleep. So I'm all for it. But I would say that don't get too obsessed with, ooh, I need to get a good sleep number, and I have patients actually just stay in bed for half an hour more just so that while awake, just to get a better sleep number. Don't do that. That actually make it worse. The next thing is really try to have a regular sleep-wake schedule because that really helps to strengthen your circadian rhythm. Circadian rhythm is very important, not just for sleep, but for your brain, for your heart, for your gut. There are more and more studies showing that if your circadian rhythm is out of whack, things just not going to work the same. So you do want to have regular sleep and wake schedule, even on the weekend. Be mindful of how much light you expose yourself with before bedtime. It includes obviously our devices. They're pretty bright. There a lot of the phones now, they do have a kind of like a dark mode or blue night mode. Basically, it's just a way to turn your phone blue light setting off, so minus the blue light. So that's good. But best is just to turn off your device 1 hour before bed at the minimum. The reason is the lighting that we have in the evening really suppress the release of melatonin. So our brain makes melatonin. You don't have to get melatonin through a gummy. We actually make melatonin through the pineal gland in our brain. And the trigger for the release of melatonin is actually dim light setting. So when it gets dark in the environment, we actually naturally release melatonin. So by exposing ourselves to artificial lighting, actually delay the release of melatonin. And that's the reason why we have more and more night owls, because we kept scrolling through our phone, not only the lighting, just that emotion associated with looking at social media all the time. That can really delay your bedtime. So be mindful of your screen, turn it off 1 hour before bedtime. If you absolutely need to use your computer for homework or for work, make sure you have ways to filter out the blue light. Think about the ambient lighting, so your room lighting. Dim it down to a lower setting. If you can pick your light bulb to a different warmth, I would say the amber yellow light bulbs are better because it contain much less blue light. So those are kind of important things to be mindful of. But not all lighting is bad. It really depends on when you use it, how you use it. So for people with seasonal affective disorder, or the time when we have daylight saving, when we wake up is pitch dark, having lighting in the morning is great. It really helps to wake your brain up, so to speak, and also actually in a way help you to fall asleep easier that in the evening. So lighting in the morning is really great to set your circadian rhythm. Daylight saving is not good because we have 2 months more of darkness when we wake up. So that's the reason why I'm pushing for year-round standard time. And for people who actually do night shifts, it's challenging. There's no question. Not only you have to work in the evening, you have to try to sleep during the day. So it's really challenging to do shift work. But you can try to make sure your work environment is bright at night. So kind of mimic that daylight. If you can't actually have bright light in your office or your work environment, you can buy these light boxes. They're available on Amazon and anywhere else. But what you're looking for is 10,000 lux. So that's the intensity of the light. If you can find one that is contain more blue, they have these blue light box. They're actually even better. If you can't fall asleep, think about when's your last dose of caffeine. Caffeine's half-life is actually 8 hours. So yeah, if you can't fall asleep, think about when's the last dose of caffeine. Caffeine is in a lot of things, tea, coffee, soft drinks, energy drinks. So definitely kind of educate yourself of what you're drinking. If energy drink can be very, very tricky and very actually unhealthy. Sometimes one can of energy drink can have like 300 milligram of caffeine, which is a lot. The FDA recommend no more than 4,000 milligram of caffeine a day. So just kind of watch what you drink and look at the bottle. But just like lighting, caffeine can be used strategically. So, I mean, this is mostly for people who work at night. I would say if you work at night and, I would say you can use small doses of caffeine when you do feel a little bit sleepy. that usually more helpful than large dose all at once, those Fenty coffee. So, but just kind of also remember the half-life of the caffeine, 8 hours. Nicotine and alcohol is not good for sleep. Nicotine from, for example, cigarettes, it's very stimulating. So a lot of my patients actually come to me and have insomnia when I, try and understand what they do. So it turns out they smoke before bedtime and they smoke again when they wake up in the middle of the night. Not good. Not good for sleep, not good for health anyways. Definitely not good for sleep. Alcohol, even though you get that little bit of sedating effect from the alcohol, may help you to fall asleep in the beginning, it actually fragment your sleep, meaning that it disrupt your sleep in the second half of your night. And the reason is that, the half-life of the alcohol, so to speak, only a couple hours. So after that, you have kind of almost like a rebound, withdrawal. So they're both not healthy anyways. I would say just try not to do them, but they're definitely not good for sleep. Try to have a routine to wind down. They do work, even though they sound so, over preached. But relaxing activity like yoga, meditation, kind of all these relaxation techniques, they do really work to kind of boost that, parasympathetic nervous system, just kind of get your body and your mind ready. Reading is great. Just kind of be mindful of the lighting, if you use a device. The best sleep environment is actually a room that is dark, quiet, and cool. So, if you live in a city or the street light is bright, try to kind of use blackout curtains or just simply wear these kind of sleep masks. They do block light beautifully. And quiet. So yeah, some people do need their white noise machine or different kind of, dark noise. They have many different noise machine nowadays. If you need to, that's fine. Some of my patients like to turn on the TV. I would say no because of the light coming from the TV. And then the temperature, it seems like it's too cold, right? 68 degrees, but that's actually proven to be the best temperature for sleep. Strategic nap. So athletes do that all the time. For example, the Penguins, they do pre-game nap because 20, 30 minutes nap or longer naps really can kind of boost your performance. For athletes, mostly because they have to play at night, a lot of night games, right? But for us, actually, naps do help. I would say stick to 20, 30 minutes naps, short naps. They're enough to boost your kind of cognitive performance without giving you that grogginess when you wake up from a nap or something we call sleep inertia. Longer naps, certainly probably more restorative, when you think about these deep sleep, those sleep stages that I showed you before. But the problem with that is twofold. One is you may have that sleep inertia, that grogginess when you wake up in the morning. When you wake up from your long nap. And the other thing is if you sleep too long, it kind of take away your sleep drive at night. So you may ending up having trouble falling asleep. When it comes to the best time to nap is 2 to 5 p.m. and 2 to 5 a.m. if your schedule is flipped. Because we just have that natural dip in our circadian rhythm, that siesta time. And then I tell all my patients, changing your sleep habit is great, but you can't do it alone. It's a perfect opportunity to educate your family, the importance of sleep, how sleep is so important for epilepsy. Do it all together, instead of, scrolling on the devices. Everybody's scrolling on the devices before bed. Maybe, turn that into an hour of, I don't know, board games or something like that, right? So do it together. And that's all I have. And we have 20 minutes left for questions and answers. So I'm going to stop sharing.
Thank you. So we do have some comments and questions in the chat. So the first one is from Dan and Sarah. They write central sleep apnea and its correlation to epilepsy and epileptiform discharges. I don't have OSA, but do have adult acquired CSA and consistent daily epileptiform discharges even on AEDs.
Okay.
So Dan or Sarah or Dr. Fong, any kind of comments or follow up to that statement?
Yeah, so I didn't mention the central sleep apnea because obstructive sleep apnea is definitely way more common. Central sleep apnea can happen in patients with kind of special conditions. For example, congestive heart failure, known brain lesion like brain tumor, um, and then there's some other conditions as well. VNS can cause central sleep apnea, even though obstructive is usually more, but they can have both. So I would say if you have central sleep apnea, definitely, I don't know your health history, but definitely mention to your PCP and kind of trying to figure out why. Make sure we don't have any cardiopulmonary conditions. Um, Brain condition can cause central sleep apnea. It depends on where the problem is. So it's hard for me to say, but for example, people with stroke and brain tumor, depending on where the stroke and tumor is, can have central sleep apnea. Rarely, a cervical spine issue can give you central sleep apnea as well because there are important breathing center, these important neurons in the cervical spine. Um, but there's I think they touch on something that is very relevant also for our epilepsy audience. You all know the condition SUDEP, or sudden unexplained death in epilepsy patients. It's a little bit of a different process. SUDEP is related to a seizure causing the heart or the lung to stop breathing or the heart stop to beating. So it's a seizure triggered event. But sometimes, when you look at the EEG, during which someone is having a seizure, sometimes we do see the heart kind of drop, the heart rate kind of drop off. I think there are several case study that shows that patient can have apneic event during SUDEP. So we still don't know a whole lot about SUDEP just because they're so rare and it's hard to catch them. So a lot to learn. Yeah. I don't know if I answer your question.
Dan or Sarah, do you have anything additional? You can unmute yourself if there's something specific related to your comment.
So just to follow up, do you think like epilepsy can cause centrals to develop, or do you think maybe vice versa?
Yeah, I would say probably central sleep apnea can provoke more epileptiform discharges in sleep. Epileptiform discharges can cause arousal, kind of fragment your sleep, make you kind of more sleepy during the day and your sleep lesser quality. But I don't think it can cause central apnea. It's a little bit less likely. Um, but I do want to kind of mention something about epileptiform discharges. For me, I think certainly our priority is to, stop seizures. We don't want seizure. We stop seizures. So seizure control. But I think it's also important to look at the epileptiform discharges burden. If someone had a lot of discharges in sleep or during the day, it actually can have negative impact on their performance. There are a handful of study looking at, I think more so generalized epilepsy patients. When they have a lot of discharges, if you treat those discharges, they actually see improvement in their cognitive performance. It actually makes sense when you think about that because these discharges generate from the brain and it kind of disrupt your brain activity in a way, those big surge of discharge. And in a way, some of my patients, oftentimes tell me that when they do have a lot of discharges, they feel like they are almost having ADHD type of symptoms. It's hard for them to focus, to concentrate. And when you do suppress these discharges by bringing the frequency down, you can improve their quality of life. So for me, certainly important to try our best to stop all seizures, but we should also not forget about the epileptiform discharges.
Thank you.
Yeah.
So our next question comes from Elizabeth. Do you have experience with DEE, SWAS/ESES and how it relates to actual sleep? Are there tricks or ways to help with these spike wave induced wakings? They seem to be abundant in a vicious cycle.
Okay. Okay. Who's the audience asking for that question?
Elizabeth.
Elizabeth. If
Can you
you're
unmute yourself, Elizabeth?
okay,
Yeah,
I
I
see
can.
your question. Okay.
Can you hear me?
Yeah. Okay.
Yeah. I think you helped answer when you were talking about the spike waves. I think my question is kind of morphed after you just explained into more of, is the goal to figure out these epileptiform discharges, spike waves, get control of those? Is there a way to sort of help sleep on the back end while we're trying to get control of them?
Yeah, so that's a good question. I mean, this is something that I often work on with my patients, right? Is try to figure out how do we better control these discharges. So it really depends. I think the best approach to your question or problem is really to get better insight of what exactly how much discharges are they only in your sleep, because if let's say if they are more so in your sleep, well, ESS it is, then I would say you can kind of strategically think about how you use your seizure medication. For example, I have patients only have nocturnal seizures. I sometimes pick medication that once a day only at bedtime. So that rise in that medication, that level, the effectiveness is during the sleep. Or you can do uneven dose, higher dose at night, things like that. But yeah, I think, it depends on where you are. You can ask your seizure doc to order you a overnight EEG. If you're near UPMC, we do have ambulatory EEG service. So it's basically at-home EEG recording. So that can really give us a lot of information about your sleep and also your discharges. Yeah, I think, there's no easy way, there's definitely, I would say, no supplements that would help, you know. Um, I think, one thing you can do, I'm just trying to think, if there are any other non-pharmacological way that can help in the meantime while you sort it out with your doctor. I would say try to practice good sleep hygiene, making sure that you do sleep your 8 hours a night, having good duration, of sleep is helpful, you know. So if you only have 4 hours and there's a lot of discharges during it, is poor quality, you know, then I think at least 8 hours would be a little bit better. So thank you, Elizabeth.
Our next question is from Christina. She's asking, can a person have insomnia and sleep apnea?
Yes. Yes, insomnia seems to, you know, you can tat it on any conditions. So yeah, it's not uncommon. Yeah. And something very interesting. Sometimes people with untreated sleep apnea, they can have insomnia. You would think that someone with sleep apnea, they're sleepy, they should be able to fall asleep, but sometimes it can have kind of like the reverse effect. If someone have insomnia and sleep apnea, treat the sleep apnea first, and sometimes you will see that the insomnia would go away. If you have sleep apnea is adequately treated and have, you know, and have just insomnia, then I would say first thing is really to, you know, practice all these good sleep hygiene. And then look at your medication. You know, have your doctor look through them, making sure none of them can cause insomnia. And then if you truly just have isolated insomnia, you can ask to be referred to a sleep specialist. You know, again, insomnia a lot of time is a behavioral issue, not always, but you know, just having that discussion with a sleep specialist can be sometimes very helpful and you know, impactful in a way. It can review something that actually can be easily fixed. So yeah. Okay.
All right, thank
Christina.
you. So next is from Kristen. She states, I take Lamictal and my neurologist never talked to me about not taking it before bed. What's a better time frame for the night dose?
Yeah. So I would say if you don't have insomnia on Lamictal, probably not a big deal. But if you have trouble falling asleep, and by the way, the definition of insomnia is if you have trouble falling asleep more than 30 minutes. So if you fall asleep within 30 minutes, that's actually normal. So the time frame, I usually tell patient, you know, if they take it 7 a.m., if you take it 7 p.m., that should be plenty of enough time before bedtime, you know. But you know, in general, if you can, I would say 3 hours, 4 hours before bed would be best. But I don't want to, you know, skew your twice a day dosing schedule. So it really depends. Mhm.
All right, thank you. From Tracy, even though my EEG is awake, is the reason they want me not to sleep is to try to catch a seizure.
So yeah, so EEG, at least in my lab at UPMC, typically we do give the patient opportunity to sleep. But if the EEG was not ordered as a sleep deprived EEG, it's probably hard for someone to fall asleep. And it really depends on also the EEG lab environment. Sometimes people talk just outside the exam room. It's really hard for you to fall asleep. Yeah, so again, I think sleep, when we record sleep on the EEG is usually to me is great because it kind of give us some additional information because sleep kind of help bring out these discharges, you know, and sleep deprivation can trigger these discharges. But you know, I always kind of caution patient if they do sleep deprived EEG, you know, because I don't want them to have a seizure driving, you know, to the appointment or from the appointment. I always have them, if they have seizure rescue med, bring that with them, and also have a driver.
Thank you. From Laura, any correlation between ADHD and affecting sleep? Child has ADHD, epilepsy, and anxiety, and has had sleep issues years before having seizures.
Yeah, yeah. Well, ADHD, certainly, patient with ADHD, whether a child or adults, they can have sleep issues. A lot of the time it's insomnia. And that's mainly related to a couple things. One is their medication. If they're on stimulant, one of the side effects of stimulant is insomnia. So you do want to kind of help, kind of work with your pediatrician or prescriber to kind of pick ones with maybe shorter half-life so that it not affect your sleep. And ADHD patient oftentimes do have anxiety, they do have a correlation. So I think, the ADHD, the sleep issue and anxiety is probably all kind of related to the ADHD. There's some correlation between ADHD and epilepsy. It's not a very strong one, but we have seen that correlation. But I would say if your child has insomnia and anxiety, is probably, I would say, focus on picking the right medication of ADHD because a stimulant can also worsen anxiety as well. So sometimes it's necessary to select non-stimulant medications for ADHD just because of those side effects of insomnia, anxiety. Yeah, I would say for people with ADHD and other kind of neurodiversity like autism, insomnia is actually quite common. The American Academy of Sleep Medicine, they do, suggest that it's okay to take melatonin to help with sleep. So melatonin, you can get it over the counter, yes, in the United States, but actually it's a hypnotic. It's not a vitamin. In fact, in some other countries like Japan and UK, Australia, you can get melatonin unless you get prescription from the doctor. So, and that's the reason why when you do need melatonin, the American Academy of Sleep Medicine just put out a recommendation. We do recommend picking, brands with the USP certified label because it's more regulated and, so you're getting what you're really getting. There was a large study recently looking at all the gummies and over-the-counter melatonin, and what they found was that the dosage of melatonin within the supplement can ranging from like negative percentage to 400%. So the 400% is not safe. If you give a child 5 milligram, you may be actually giving 20 milligram. So yeah, USP certified label melatonin can be used for people with ADHD and neurodiversity conditions like autism and other conditions. So thank you, Laura.
Thank you. Next one is from Donna. You didn't mention BiPAP. I know from having been married to someone who set up patients on CPAP that many people seemed to tolerate bi-level pressure better than continuous. Have you experienced this?
Yeah. So, the process of getting CPAP, I want to kind of, for the rest of the audience, so you have the sleep study and that confirms, yeah, you have sleep apnea. The next step is to get the CPAP machine. So to do that, there's now two ways to get the machine. So you can get the second part of the sleep study, so another sleep study in the lab. They put the machine on you. Always start with CPAP. and basically go up on the pressure setting until we don't see any more sleep apnea. So that's what we call CPAP titration sleep study. Sometimes CPAP, people cannot tolerate the CPAP, or if they have like other cardiopulmonary condition, they may actually need bi-level PAP or BiPAP. But usually we try the CPAP first, and if that person cannot tolerate or is not enough to eliminate sleep apnea, then we go to bi-level PAP. And then there's something called RSV, even more advanced type of machines, but we usually start with the CPAP.
Thank you so much. So that is all of the questions in the chat. If anyone else has any questions, we'll kind of do a last call for questions in the chat if you have any. I know that I learned some new things tonight. So every week I'm learning new things, which is great. So I hope you all did as well.
Absolutely. I have one last question for you, Dr. Fong, if you don't mind. I heard recently in some studies that females might need more sleep than men. Is that true? And if so, how many hours do you recommend for females versus males?
Oh, that's really a hot topic for discussion. There's really no consensus yet. So right now I'm still recommending all adults to sleep 7 to 9 hours. I always advocate for 8 to 9. But yeah, maybe by next year we'll have more data and we can look into those information. But right now there's no different gender recommendation for sleep duration. But very good question, very timely.
Thank you. And it doesn't look like we have any other questions in the chat. So thank you so much for giving us your time this evening. And we appreciate you all joining us. And hopefully everyone joins us next week as well for Dr. Lorna Myers and her presentation on PNES.
Thank you,
Okay,
everybody. I
thank
hope you
you.
all have a good night.
Thank you, everyone.